Good morning, good afternoon, good evening to many people around the world who are joining us today. Thank you for joining us for this webinar on AI revolutionizing global health, innovations and impacts on FBOs. While we wait a few more minutes for others to join, please introduce yourself with your name, organization, and where you're joining from in the chat box. And we'll get started in just a few minutes. While we're waiting for others to join, you may enter the link that's shown on the slide right now that's going to come up here in the chat in a browser to access the translation if you want to read the translation. You can listen at this link as well, but it may be very difficult to reduce the sound in Zoom while keeping the sound on your other browser. So please feel free to do that. We use Wordly artificial intelligence for translation. Wordly provides written translation and audio interpretation. That audio interpretation information is available on the screen right now. So step one, to listen to the interpretation, we recommend opening this QR code on your phone. When the Wordly site opens, if you're asked to enter a session ID, it is the XMPWP-0889 that you can see, and the passcode is 259670. It's all shown there on the screen. Step two, choose your language. Step three, you can turn down the volume of the audio of your original language in Zoom so that you can hear your desired interpretation language. You can also use the link that's there that we're providing so that you can listen at that link as well, but it may be very difficult to reduce the sound in Zoom while keeping the sound on your browser. And we'll get started in just one more minute while people are still coming on. Seeing many people joining already, so glad to see people. Please introduce yourself in the chat box so that we know who's joined and from where. And please note that questions should go in the Q&A box. So when we do get to ask questions from all of the people participating in the webinar, please use the Q&A box, not the chat box. So you'll see Q&A at the bottom of your screen. Use that for questions. We'll be monitoring that. Good. I hope everything is clear with the translation. And we can go ahead and get started. All right. Well, it is our pleasure to welcome you all for the webinar on AI Revolutionizing Global Health Innovations and Impacts on FBOs. My name is Doug Fountain, and I'll be the moderator today. I am the Executive Director of Christian Connections for International Health, and I'm based near Washington, D.C. Thank you very much for joining today from different parts of the world. We're really grateful with the large turnout for today's webinar. For those of you who are new to us, CCIH is a global network of over 100 Christian organizations, as well as secular and interfaith partners committed to advancing health and wholeness. CCIH members work in over 90 countries globally. These members include non-governmental organizations, church networks, Christian health associations, volunteer and product donation agencies, and other support organizations. So to our topic today, well, CCIH spends considerable time considering how global trends affect the faith-based health landscape and how faith-based partners contribute to shaping the future of health. AI, artificial intelligence, is, of course, on everybody's mind. I certainly grew up watching frightening science fiction movies that feature AI that gets out of control and has bad effects on the world. And so I think some people have an inherent fear of what this is, but it's more realistic that many of us simply don't know what it means and how it might change our work and our lives. The reality of AI is promising. Many people think AI will drive healthcare efficiency at scale by empowering people, frontline workers, and research in ways that will speed up access to healthcare, speed up diagnostics, speed up drug development, speed up clinical decision making, and speed up utilization. But we know that efficiency is not just speed, it also includes effectiveness. And we also know that the drivers of effective healthcare are not the same everywhere. Faith actors have a special contribution to make to effective healthcare as well. So we have questions about how AI will work in low and middle income countries and how faith-based organizations will be affected and can influence AI. This is why we wanted to take time to dive deep into AI, what we know now, and think how we might influence the AI agenda. Frankly, I had to read up on this, and later today, I'll share 4 great resources that I think are important reads, including one written by one of our presenters, Alice Howe, as well as a USAID publication and 2 journal articles. So hang on, that will come after we get through the discussions today. I am pleased to welcome our 3 panelists. With a variety of experience and expertise in health and AI, we'll get an overview of where we are with AI, some specific discussion about its use among faith-based services, and a discussion from a global partner about the ecosystem for technology and change in low and middle income countries. First, we'll hear from Alice Howe. Alice is a machine learning engineer at Block, a company that is behind products many of us know like Square. Alice has broad experience ranging from the startup ecosystem of Silicon Valley to serving as a fellow and professional staff member on the Senate Commerce Committee focused on investment into application-oriented technology research. Her work culminated in the passage of the CHIPS and Science Act. Then we'll hear from John Hurst, the Chief Innovation Officer at SIL International. John leads SIL's efforts to engage with AI and has 25 years of experience in championing innovation in the nonprofit sector. He has a background leading technology, publishing, marketing, communications, and research efforts for nonprofits. And then finally, we'll turn to Peter Yoboa. Peter is the Executive Director of the Christian Health Association of Ghana, which is CHEG, which is the largest private not-for-profit and non-state provider of health services in Ghana, with more than 25 years of experience in managing the health sector at both policy and practice levels. Peter served on a variety of national and international global health committees and boards. We'll hear briefly from each of them. I'll put some questions to them. We'll have a chance to hear their responses. And then we'll have a discussion as a panel before we open it up to other questions. So again, please do put your questions into the Q&A box at the bottom. I think we're going to show the instructions for that one more time, if I'm right. There we go. And again, if you've just joined, this is how you would access the translation. You can use the QR code and then select your language, and you can listen on your other device. That is the best. All right, and again, the questions, please put them in the Q&A box, not in the chat box. That will help us. All right, well, with that, I think we're going to first be joined by Alice. So Alice, welcome.
Thanks, Doug. Excited to be here today.
Yeah, thanks for joining us. We appreciate that. And Alice, you wrote something for Stanford University's Center for Human-Centered Artificial Intelligence on the broad reach of AI and health. Could you just give us a basic primer on how AI will change healthcare generally?
Yeah, definitely. I think one thing to note here is that although large language models and things like ChatGPT have been all the rage in the last 2 years, AI in healthcare really spans beyond just that technology and touches on leveraging older techniques as well in computer vision, forecasting, classification, in addition to language models. And these have impacts across different parts of care in healthcare. So you mentioned a couple of these in your introduction, but one area of impact is in diagnostics and imaging. So, for example, using AI algorithms for computer vision to analyze medical images like X rays, MRIs, and CT scans with high accuracy to help care providers identify different conditions like cancers, fractures, and other neurological diseases. A couple other areas are in personalized medicine. So AI has the ability to analyze really vast amounts of patients' data from their previous histories and predict how, for example, specific individual patients might respond to different treatments or identify insights specific to those patients, provide to their doctors in helping them provide current care. Another area would be in operational efficiency. So, thinking beyond just medical diagnostics and to the overhead of actually managing the operations of a hospital or other care settings, where a lot of effort is spent on triaging patients to the right departments. Emergency rooms can be really occupied and very expensive to maintain. So, making sure that the highest need patients go there and otherwise get triage to different departments can really increase the efficiencies of how a health operation is run. One other area that could be really applicable to sort of remote patients is in remote monitoring and telehealth. So we've all probably seen things like Apple Watches, but there's also a lot of research into other kinds of telehealth platforms and wearable devices. A lot of this research was spurred, especially during COVID and the pandemic, when it was harder for patients to get in-person treatment. And these types of devices often provide real-time monitoring and detective algorithms that can help to proactively identify risk factors. So there's been research, for example, on letting patients use their mobile phone to take images of their eyes to detect diabetic retinopathy, where computer vision is applied to those mobile phone images, or using wearable data to proactively identify stroke risk factors. So there's a lot of innovation in thinking how can we use these devices that reach patients where they are to be more proactive in providing their care. And then finally, kind of similar to, in a similar vein, is using AI models to predict large disease outbreaks. And this was also especially a thread of research during COVID, but thoughts on sort of identifying and modeling network effects, especially for contagious diseases, so that we can identify which communities might warrant more attention from healthcare providers.
Remarkable. I met with an AI organization a few weeks ago that has a way of tracking on Facebook and social media discussions about diseases. And then from that, they're able to identify patterns and also identify who are thought leaders in that space. So on that point about surveillance and helping with public health, that's remarkable. Thank you for that. What are some of the major challenges? Again, you live very close to the AI infrastructure in the AI world, but most of us who don't, what do you see as some of the major challenges and opportunities that AI presents for improving healthcare, especially in resource-constrained regions?
Yeah, so one of the big challenges in AI generally is getting the training data to train these algorithms. So in the US, there are strong kind of patient privacy frameworks for governing the use of patient data. And all machine learning algorithms require a large training set to train on to be able to, for example, like a large training data set of MRI images or X-rays in order to learn how to identify kind of certain conditions. And one of the challenges is many of the universities conducting this research will often just go to their local hospital or their university hospital to collect this data. And as you can imagine, not all of these universities are very geographically diverse. They might skew towards a certain demographic as well, especially at Stanford, which is close to Palo Alto. The Stanford University might skew towards sort of a wealthier, healthier sort of population than in another part of the country. And this has led to algorithms potentially being biased or unable to effectively detect certain conditions in different populations where you apply the algorithm to a different domain of people. So making sure that sort of resource constrained regions or areas that are not often partnering with academic research labs get their data into the mix so that these algorithms can be effectively trained on that population is a really huge challenge. And it's something that I worked on with the Senate Commerce Committee, thinking through how can we work with a federal agency like NIST, the National Institute for Standards and Technology, to work with different hospitals or kind of institutions that have a lot of this data and get them to share it with people who are doing the research and training algorithms. A couple of other areas of challenge would be in infrastructure. So thinking about how resource constrained regions or different parts of the world might not have access to as reliable internet or electricity, advanced computing infrastructure. These are things that are needed to be able to run certain telehealth operations, have access to the cloud where you can access these algorithms that typically don't run on device. And then have like network bandwidth to be able to send monitoring information back towards these algorithms. And the last area that I would want to raise is sort of a patchwork of regulatory standards or ethical standards for working with these technologies. So not everywhere might have the same kind of regulatory frameworks for managing patient data or ensuring low degrees of bias or patient opt-in and consent for working with these algorithms. So I think one challenge will be sort of unifying some of those standards or ensuring that patients are protected wherever they are, regardless of where these algorithms were trained.
When you were speaking about training the data and it being focused around a few geographic centers, I remember when you spoke, I had not realized that issue. I think of that as the modern equivalent to it's the 21st century equivalent to the last century where textbooks on health were written in high income contexts and then brought to low income or low resource contexts as though the same principles apply there and the very models apply. So yeah, that makes sense. Alice, thank you very much. That was really a helpful primer and intro to this. And we'll come back to you with some questions in a few minutes. So thank you. Next, we're going to hear from John Hurst, who's the Chief Innovation Officer for SIL International. And John, I know we've had some conversations around this, but let's talk in terms of enhancing communications. And I should observe, even on this webinar, we're using Wordly for translation. Wordly is an AI-powered translation. So how is AI improving language translation services, and what impact does this have on communication between healthcare providers and patients, especially in multilingual communities? We'll start with that.
Sure, sure. The impacts are huge and very dramatic in ways that we wouldn't have imagined. So I was recently with one of our field workers from a country in Latin America, and she was describing how the government in that country was really making maternal health a priority, but the only language the materials were in was Spanish. And she was working in a community where there were some Spanish speakers, but simply delivering Spanish information was not going to have the impact on the lives of those moms and those women that the communities that the government really wanted to have. But the challenge that they had was that the government had no money, no resources to expand the languages that was in. And I think what we're seeing with AI is it's putting deeper and more meaningful communication essentially within reach of NGOs, governments, and healthcare systems. See, in the past, people would have said, hey, that's just not really an option. I don't have the money, I don't have the people, I don't have the time to get it into all the languages. There's over 7,000 languages in the world today, and most of those do not have any of this information available. AI doesn't solve the problem completely because fundamentally it's a problem of human connection and engaging around information. But AI adds a level of bandwidth and muscle to the problem that makes it more within the reach than you would have imagined it being even 2 or 3, 4 years ago. So that's, I think, one of the areas where we're really, really seeing the impact come out in a significant way.
Did you just say that it adds bandwidth and muscle? That's a great turn of phrase. I love that. Um, how do you trust the data? So Alice just spoke about training the data models. Maybe you can unpack a little bit about your comfort or your feeling of trust with the underlying data that goes into the AI models.
Yeah, we have this, depending on our posture, we either have this natural distrust or natural overtrust. And I've seen both, in many people's postures towards AI. And I think, we all have heard the phrase garbage in, garbage out. And it applies to data with AI, meaning the quality of what goes into the systems generates then the quality of what comes out. And the representativeness of what goes in leads to representativeness coming out. And so this is really a huge issue. And Alice described it very, very well at the policy level. I think what I would say is that essentially what our situation is that we have to assume that the data in these systems is as unrepresentative as our natural experience has been about the access to healthcare and healthcare information around the world, which is very unrepresentative. And we have to then augment these systems and look for, essentially interrogate them for the holes. I was really impressed. I recently read an article by Genevieve Smith. She's the Gender and AI Fellow for USAID. And what she was describing, for instance, an example of a chatbot that was being used, I think, by the government in Nigeria. And they were finding out that as they interrogated the chatbot for how it answered, it tended towards answers that made most sense for urban dwellers and certain demographics. I think women of certain ages and single men, for instance. And so what they realized was, if this is really going to be a helpful tool for us, we're actually going to have to go in and fill in data gaps that this chatbot has relevant to the audiences we really want to serve. So in that way, the data should be interrogated with a fairly discerning eye, because you should not assume that it is less biased and discriminating than our day-to-day experience that we have out there serving in communities around the world.
Remarkable. I'm not sure how to do that, and that's part of what we're going to stir the pot on a little bit here. I wonder if you have any final thought before we go on in terms of implementation, the key challenges in implementing AI-driven translation tools that you see.
Yeah, well, Alice has mentioned a few key ones. Data is a key one for sure, and she mentioned that one. What I would add to the data one is that one of the blessings and opportunities that we have. SIL, of course, represents an effort to help people flourish with the languages they value most, and health is a key part of that. But a huge part of our heritage is working with Bible translation. And there are thousands of New Testaments and hundreds of Old Testaments. And these data sets in minority languages around the world, local languages, are going to provide key opportunities for us to train models to support minority languages around the world. And so in my mind, God's word is going to be, I hope, an answer to helping us give people access to the health information they need in ways we would have never imagined when 40, 50 years ago, someone was working on a translation of God's word into a certain language. So I think the data one's a key one. And the last one I would say is really integration of AI into program delivery. It's one thing to have this great AI that does a certain thing. It's another thing to really make it a co-pilot and a help to a human who is ministering to another human. That just requires a level of discernment and interaction that we're just very new at right now because the technology is so new. So that's really one of our key challenges, I think, is how do we embed it in appropriate ways, in ethical ways, into our program delivery so that the human is still being valued and honored, but these tools are being used where appropriate. I think that's a great challenge we
Remarkable. I think we're getting a good list of those challenges, building on what you've just added to what Alice had shared before. Really helpful. Thank you, John. That's really really helpful in unpacking from SIL and from the language perspective in that for us. We're going to move on now to Peter Yaboa, who is the executive director of the Christian Health Association of Ghana. And Peter, there's a lot changing with all of this, but a lot of things have changed already. So first off, welcome. And what is the state of discussion about AI in Ghana's healthcare system? In terms of managing health systems or delivery of services? Is there much discussion, or what are you hearing there?
Yes, many thanks, Doug. And it is exciting to be reunited with friends and colleagues via the power of internet. Certainly a form of AI connecting us through interpretations. Certainly, when I listened to the merits, merits of AI and its potential in utility and ensuring access, equitable access to quality, affordable health services, addressing issues of coverage, cost, quality, efficiency. One would think that, everyone should adopt AI immediately. And so much so that in my own country, in Ghana, we have been having media discussions on the prospects and potentials of AI and its value proposition, the entire health system. And what I've known so far is that our Ministry of Communications and Digitalization has set up some committee discussing it. But the issue of AI has not, even though part of digital health generally, it's not really on the radar of health policy by the Ministry of Health. So there's that leadership gap in even discussing the whole issue of AI. But for us as faith-based organizations, we are pioneers of innovations, but probably not so much of early adopters of technological, innovations like AI. And so certainly we have been having discussions on how we can really onboard AI as an enabler, accelerant, to promote universal access to quality health services. And so now the posture has been, why don't we wait and see what happens? But the reality, though, is that it is a new wave of change, innovations, novel tool for improving access to quality health services generally. And so there's a leadership gap in profiling the issue of AI on the health policy radar. And as missionaries, I think that if you listen critically on the submission by my earlier colleagues and friends, certainly AI could be an important pathway of helping us fulfill our core mandate of ensuring equitable access to health services to those who are unreached, deprived, marginalized, and neglected segment, and of course, meet the core principle of equity ahead of efficiency, effectiveness, economy. But equity is very important in the whole architecture of AI development and use of it. So that would be my preliminary comments. Very high, not much traction, but we see AI a lot in the education sector, in energy. In the health sector, I think we are a bit hesitant in onboarding the whole issue of AI. Why? Probably subsequent discussions would unravel why we are a bit hesitant in uptaking AI on scale.
Remarkable, especially given something that Alice mentioned about the data safeguards and how data are being accessed and utilized. And we'll come back around to a few of those themes in the discussions. It really strikes me. You really got me with something I just want to pick up on about the missionaries as innovators. And you're the missionary, you're the innovator. Chag did a lot to help set up the national health insurance system in Ghana, and that became the national health insurance system. And so using that voice or that role as innovator is something that is familiar. So I just want to emphasize that. Thank you. Let's put a public health hat onto all of this. And there was this idea that we can use AI to help with surveillance of what's happening in communities. And I did mention a few minutes ago that there's an AI executive who's using Facebook to be able to track what's happening, what people are talking about. Uh, Setting it in terms of this policy context where people are saying, well, let's go slow. Uh, is there a concern or is there an opportunity? Is AI being used or discussed in ways to strengthen health surveillance specifically, or what do you think about that?
Yeah, absolutely. I think AI has potential multiple uses to ensure the provision of broad spectrum of health services, be they creative, promotive, preventive, and all others. And I think the experience of COVID, affirmed the use of like telehealth or remote care type of. So AI definitely potentially could be used to improve public health. Certainly in an area of disease surveillance and then of course detection, disease surveillance and then intervention. AI potentially could be very helpful in mapping, looking at incidence prevalence, drawing patterns, but this is much more feasible probably if we have reliable data so that we'll be able to draw patterns and data in terms of quality and quantity, and also interconnection with certainly non-health sector variables like meteorological services, weather, and demographic data to improve public health. And it can even be used for messaging. And if AI could really be able to do some scanning and scoping of potential determinants of health, it will help us, appropriately target interventions that will improve public health and well-being of the entire system. But as I said, it is contingent upon quality data and of course sensitive also to weather patterns, climate change, demographic data, and the way the entire system would harness AI properly. So the prospects and potential of AI to improve health generally is very great. And we are even looking at in future, how can AI even be harnessed? I'm talking of telemedicine, of course, telehealth, and reaching out to provide services. I mean, we mentioned maternal health, trying to predict communicable and non-communicable diseases. Remember, Africa is always a hub. I mean, an unfortunate recipient of communicable disease, outbreak and NCDs. Certainly, AI could be a vital instrument in seeing how we can harness it throughout our system, even in terms of personal care, messaging, in terms of behavioral change, communications or direction, weight loss and other things that we could really harness to promote health and prevent diseases all over. So certainly it's a potential public health tool, but much dependent on certain enablers, as I've mentioned, data and of course, interconnection with other key enablers to ensure that we optimize AI for health and well-being of the population, especially those who are unreached and marginalized segments of the society.
Really helpful. Thank you. Thank you for that. And again, I sense through all three conversations the balance of promise versus accelerating the good features and the promise against balancing the known limitations, and that makes a lot of sense. So participants, again, a reminder, please put your questions into the Q&A. I'm seeing some come in, and we'll get a chance in a moment to turn to some of your questions. So you can put it into the Q&A box at the bottom of your screen. I would invite now for Alice and John and Peter and I to all be together, and we can have a bit of a chat about some of this. And I'm going to start, Peter, I'm going to start with something that you were sharing and kind of go backwards from that. The faith perspective, the fact that the faith-based providers are innovators and add value in some unique ways. If all the models and practices are based on secular or non-faith data, what do we think could be missing from faith-based health services that deal with holistic health, spiritual practices, and community engagement more than some of the secular models of care that we see. Do you have any comments about that? To any of the three of you that have
Very
a
well.
comment.
Yeah, very well. I think that is an existential question about who we are, our identity, our values, our ethics, beliefs, and norms, and how we exemplify or objectify this in fulfilling our mandate. Certainly, Alice spoke of algorithm bias and discrimination. I mean, if faith-based actors are to optimize AI, then certainly we should be involved in the development and deployment of AI, very important, in learning the language of AI or being nuanced in digital health generally and influencing, the architecture of AI itself to reflect our values. Remember, what we are noted for, or our brand, our levers have to be with empathy and compassion. And how do we change the language or influence the language of AI? I think that it's time for us to look at, influencing the policy regulation of, to ensure that AI becomes far more responsible, sustainable, and ethically acceptable in the way we do that. As faith-based actors, certainly we have key constituents. We have a responsibility. We are also very much obliged to see how any innovations, as novel as it is, could be harnessed to fulfill our core mission. And I mentioned presence at the policy table because if you are not at the table, you end up in your menu. AI is an evolving phenomena, and there's gap in leadership. And we know in sub-Saharan African health systems, faith-based actors definitely have had certain convening platform and influences in shaping or setting the agenda of health policy development. I see this as an opportunity to see how we can really, engage in partnership with key actors, with politicians, partners, professionals, and as providers. I think we have a say and a stake in the way AI evolves to reflect our core values of, of service, humanity, and interface, the human and artificial intelligence that are required to provide services. Definitely, the art and science of AI should reflect our collective Christian values. And I think it is time, if we allow the vendors who are now coming up strongly to come in, to be well established and entrenched. And remember, our political system is also vulnerable in many ways. I think faith-based actors with our stability, longevity in the system, and the trust and confidence that are reposed in us have an opportunity to shape the way AI is well deployed in a responsible, sustainable, and ethical manner. I see this as an opportunity, an obligation for faith-based actors to make a humane intervention as soon as very possible in order not to be left behind in the ongoing wave of change. A new reality we can't ignore, but an opportunity to change the trajectory and architecture of AI.
Awesome. So in a world of where there's algorithm bias, fix it, and faith leaders can help lead the way.
Absolutely.
Any other comments about this role of faith actors or concerns about ways to strengthen the voice of faith actors in this? John, Alice, any perspectives?
Yeah, I would add two things. One is we need to understand the baseline posture or perspective that these models are being built with. I just read a great article on the AI model called Claude. It's called Claude's Character. And all the effort being put into the character development around a model, which sounds very counterintuitive and a little concerning in some ways, but this is how they're thinking about it. So there's baseline postures that the models are being built with that are designed to serve as many people as possible, which means they may or may not be very relevant to our faith background and perspective. But then the second thing is that we have a ton of wonderful, amazing faith-based content around health. And all of that content can be used to do what we call fine-tuning of these models, meaning you take a model and then you take core content that's high quality, reliable, and trusted, and you use that to fine-tune models so that they begin to provide the kind of input that really represents our faith well. And so I think between understanding the core fundamental way that the model's designed and what it's going to give you naturally or natively, and then fine tuning models based on our values and our approaches, I think we can navigate how we integrate our faith into the use of some of these tools.
We're living in an unprecedented age in terms of data access, also from faith-based partners and organizations that may not have existed in the past. And so that makes a lot of sense. Thank you. Alice, turning back to you then, the mechanics of how to influence those models. I know this isn't the question, and I'll turn to the participant questions in a moment. But even as John was talking about Claude, I don't know who Claude is or how how the model works, what that, how to influence that. How do you actually get that influence integrated? How can we make a difference in that?
Yeah. So to give, I guess, a very quick overview of how many of these large language models are trained is it's actually very simple. You provide a raw text corpus, which for many large language models, including ChatGPT and Claude, often includes the Common Crawl data set, which is essentially all indexed web pages on the internet. So that can include Reddit, Tumblr, anything, Google, like news sites, anything there and all the language. And then you teach the algorithm to just predict the next word. So given the previous, for example, 3 words of the weather today is, and then that comes from some corpus somewhere, the model predicts like 70 degrees and sunny. And so the model learns to fill in the blanks for all of this text data that exists on the internet that has been publicly available for quite a while. And pretty much all of the large language models that you see have been taught to write language in that way. So one of the concerns for a lot of businesses, for example, is that Reddit data is not necessarily very representative at all of how you might want your customer support agent to chat with a customer. Similarly, you probably don't want your doctor to sound like the typical Reddit user who's posting anonymously on many of these forums. And so one of the challenges is in curating a data set such that the model adopts a tone and voice and knowledge base that is accurate to the domain that you want that model to work in. And so fine tuning is a method where you can take these models that have been, they call it pre-trained on this broad internet data, and sort of get it to focus more on a different set of text to speak and sound more like some other kind of more curated set of language that you have. One of the challenges there is the amount of data. So many of these large language models trained on the internet, we're talking about tens of trillions of words approximately that they need to be trained on. And so one of the challenges is probably in like a faith-based context, do you have tens of trillions of words that you can train a model equivalently on? Mm-hmm. Some people have gotten around this challenge by generating synthetic data sets. So for example, Microsoft this year came out with a model that they trained on a lot of synthetic textbook data. So they recognized this problem of large language models being trained on sort of garbage internet data, and they said, can we make a smaller model trained on a smaller set of data that is really highly curated? The challenge, though, is there's a lot of copyright protections for existing textbooks and other books. So they had a model generate fake textbooks almost, inspired by actual textbooks. So that way, this model could learn from language that really resembled textbook-like reasoning, and they could circumvent the issue of using raw internet data. So synthetic data generation is a big area of investment and research as one possibility for creating really high quality data sets for training these models.
That's remarkable and terrifying altogether. There to the idea is, but that actually makes sense, and the key action is to keep up with publication, keep up with the research, make sure that our work and the value that we're adding as a faith-based sector is getting into language that can be accessed and indexed, as you say. Thank you. I'm going to turn to some of the questions that are coming. We're now getting several questions from the audience. So I'm going to go back to the very start of the questions. And Alice, this is directed to you. There's a question about several decades ago, there was a lot of work on expert systems, including in medical applications. And is expert systems still an area of work relevant to global health?
Yeah, so I admit I don't know the exact terminology of expert systems, but in the research that I've come across, there's definitely still a lot of ongoing work for developing AI systems that support clinical decision making and diagnoses. But I think that where folks are leaning is towards requiring human in the loop or having that be the default case where an AI is not meant to replace a human practitioner, but instead really to augment their capabilities and sort of reduce some of the cognitive load that they have. So one example of a startup doing this is a company called K Health, which I've actually used at one point. They provide kind of like a chat bot like interface where you can provide some of your symptoms or kind of health concerns, and then you're paired with a health provider who I think in the background they receive some kind of possible diagnoses from the AI system, but then it's still up to a human to ultimately review what is the output of that. And that's to address, I think, a lot of concerns around you don't know exactly if these AI systems are biased, what data they were trained on, and ultimately you still want to have a human practitioner there to make sure that nothing has gone off the rails and to sort of double check the work of the AI.
That makes a lot of sense. Probably like a lot of casual users, my first place to turn when I have a question that's medical is WebMD. I don't call it my physician. I look at WebMD and hope that it's giving me good information. Same kind of thing. There was another related question. We've seen in the news that LLMs are not perfect. They put out bad results and even invent information. How accurate are medical or epidemiology systems? How often is the output wrong? I guess the other question is, how do you know? How do you know, or how is there a way to know or track?
Yeah, I'll speak just to the LLM case here. I think that's a sort of unique and different from other types of AI systems. But like I was saying, since LLMs are trained really to predict the next word, you can think of it as when they're given some history or context, which perhaps could be a patient's history, they're just generating the next word that would come after, assuming that they were responding to that patient history. So in the background, an LLM is thinking, say I have a distribution of words, which could be something like a cold, a stroke, a fracture, etc. They're assigning a probability to each of those words. So maybe stroke is like 78%, a cold is 20%, etc. But just like how probability works, it's a bit random. There's not a certainty to their answer. They have a sort of likelihood internally, but there's a chance that you sample from that distribution and you choose the thing that had a 20% likelihood of being chosen. So the LLM doesn't have an internal model of facts in the same way that a doctor would, where a doctor might follow sort of a decision tree to say if you have this symptom plus this symptom plus this, then you must have disease XYZ. And LLM is probabilistically generating results by predicting the next token in a sequence. So it's not quite right to think that LLMs can even reason in the same ways that humans can, but perhaps they can provide good guideposts because they've seen a lot of kind of historical data such that probabilistically what they generate might be kind of accurate. But one of the biggest challenges in LLM research is in evaluation, which is many of these companies and researchers don't even have data sets that say, given all this patient history, what was the correct diagnosis. And so there's a lot of work going into creating those data sets that are usable by LLM providers to even evaluate their systems. You'll see kind of in the news, like a lot of benchmarks are always being saturated. Like every week there's a new language model that beats humans at something, which could be like the LSAT or some like medical like test exam or something. But the challenge for a lot of those is that the benchmark is just some set of 500 LSAT questions or 500 medical Q&A questions. It's not comprehensive of all the possible situations that a health provider could come into contact with. So it's really important to pay attention to exactly how has the model been evaluated and what's missing from that evaluation data set.
Hmm. Really helpful.
Doug, I would say that one thing that I think is helpful here is to think about it a little bit like when you're a mentor to someone. You don't start them on the hardest question first when you're mentoring someone. You start with something higher level, more abstract. You then work with them over time, and as they become more proficient, have more data points, experience, they then have the ability to do things at a deeper level. I think we have to think a little bit like that when we think about these models. These models are very infantile in a lot of ways because they're only based on what they have to go off of. And so we have to start them on tasks that are more generic, abstract, analytical. And then before we drive down, as they get more and more data, to the more nuanced tasks. And so I think if we start with things that they're capable of today, then we figure out when they're capable of some of the more nuanced tasks, where today we're seeing a lot of hallucinations and things that really aren't very helpful at this point.
That's really helpful, and a great way to conceptualize the approach on that leads me to another question, which I'm seeing also from several of the participants, which is, are there tools out there that we already know of that you have seen in use that are useful in the public health or general health space? Is there something, we all know Chat GPT, and we can sign up for that, and I can tell you my stories of how it has helped me come up with information that I needed. But are there things in the public health space that you've seen already, or do we not know yet? What are the helpful tools out there? That's for any of the three of you.
Well, I'll just start us off with one. I've been really impressed with an article I saw about China's AI hospitals. And what they're doing is they're making a hospital full of different AIs playing the different roles of patients, nurses, doctors, administrators. Um, and they're simulating, essentially, these are agents, what's called AI agents. They're autonomously doing things that they're programmed to do. And they're doing all the jobs in a hospital, for instance. And what it's providing for people, for medical students in China, is the ability to essentially do training. They're interacting with the AI hospital components, and it's a way to get real life or situational training that is way more scalable, extensible, doesn't require as many human professors and things. So in my mind, there's a real opportunity for these AI hospital training environments to be a place for training hundreds and hundreds more healthcare workers around the world.
And what's it called again?
I'll share the link for you to send out in the notes, but it's an article called China's AI Hospitals, and I'll get the link for that.
Any other specific applications or tools that are coming up in discussion that anybody has seen? This is telling. So we speak about AI in terms of how it can inform things, but now the question is, how do we translate that into practice? I can say I was at a meeting a few months ago and spoke about how we use Wordly for translation. Now we have to pay for that translation service that we're using. It turns excuse me, it turns out to be not very different, maybe less expensive than paying for human translators, but it is a remarkable tool. Now, Wordly is a good app to use for translation. There probably are others that are coming along. But maybe that's something that CCIH can also help be paying attention to, is what are evolving tools or things that people are sharing that we would urge the faith-based providers are at least look at. Peter, you look like you're gearing up for a comment there.
Yes, certainly. My stony silence on the question demonstrates how faith-based actors are yearning for some investment in AI and piloting, trying to wait for proof of concept to see how we can really also be beneficiary of the AI development. Because our concern is that if there's no balanced investment or fair distribution of AI experiences and novel, this may accentuate health inequalities in country, out country, and across the globe. And so such innovations that could potentially improve disease surveillance, of course, case detection, improving public health, and the rest, to me, are extremely important. And I think as we have the discussion, one of the key principles we have to ask as equitable access, and it is about the way we conceptualize the investment case for AI across, but especially faith-based actors that have a role to ensure the fair and even spread distribution and access to the quality health services. So that would be my intervention. And so my silence was an expression and a yearning for inclusive participation in the whole AI, agenda. Over.
Well,
and I think
me.
I speak for other colleagues, and I think I speak for other, actors, colleagues on the African continent, that we welcome the whole AI discussion, and yet we think that it is time that as a constituent bearing about 25% of global burden of disease, I think we could be an important hub to be a partner in the AI evolution, revolutionize the way AI evolves all over. Over.
Well, it's remarkable that particularly in Africa, the Christian health landscape is a highly scaled, sophisticated sector of health provider, but is often looked at second after people look at partnerships with governments. And so as a source of innovation, it's an opportunity to come around and have a focus, and even a focus where you could do multi-site studies within a single context, which is faith-based context. So, Peter, that makes a lot of sense to me. And I'm looking at the questions that are coming, and several of them still are on this thing about show me a practical application, show me something that is concrete that I can get hold of. And I guess one thing that I would say, looking back over the past 30, 40 years, there have been many efforts to create protocols. And governments love to create protocols. They will put out a protocol for you're a 5-year-old child with malnutrition and malaria, and you come from this part of the country. Therefore, here's the treatment regimen to follow. And we might hope that those protocols would become better informed and more responsive as the quality of data underneath them goes. But it still is going to be up to an individual to use that protocol. Or decrease confidence that people have in following the protocol.
So,
repeat the question again. Will AI increase or decrease confidence that people have in following clinical protocols?
Yeah, very well. Sorry, I didn't realize the question was directed to me. I had Alice.
It wasn't. It was open to any.
Also, yeah. So probably I can start. I think the whole issue has to do with trust and acceptance of AI. Trust is the biggest social capital. And of course, you can also accept something when you have the requisite knowledge and probably a fair or nuanced appreciation of what the whole AI contains. So what would be very helpful in implementation of whatever protocols that are developed and of course want to be deployed has to do with how do we at the conceptualization level include onboard key actors, service providers. How do we enhance capacity training, upskilling? Very important. So it highlights the issue of human resource development for AI. At the moment, in my country, Ghana, and I think that could be the case, I'm not sure we have any fair amount of AI engineers. I'm not sure about that. I'm not sure that the entire health system is probably being prepped up for integration of AI into the system. But then the good thing though is that we are fully embracing digital health. There are digital health policies, and I think we could leverage the digital health policy space, by onboarding AI, what it means is that, in designing whatever AI application, we have to look at feasibility of implementation and how we can prepare and prep this entire system to embrace, AI and assure the system that the AI will not be misused or abused or overly monetized or commercialized to the detriment of the key actors. If that is done, if that dialogue is initiated and assurance is made, I believe strongly that whatever recommendations, whatever products that are recommended or put forward by AI would have trust, confidence, and acceptance, and ensure that implementation will lead to optimal health outcomes that we all expect. Over.
Doug, one comment on that. I think one of the very simple, practical applications that I've already seen demonstrated when I've interacted with several startups is that your phone, with an app that is powered by AI, you can hold it up to your heart, for instance. It can read your heartbeat and then do some analytics based on that and give you some input back. There's another startup I've seen where you hold your phone up to your mouth and you cough, and it actually is able to detect, based on the cough, different things that you might be dealing with. I think that the trust in AI will go up when simple things like that work. So when you break down the protocols to very simple little things that are practically helpful to a human today, that relieve stress on the medical system, that increase agency of the patients, and it actually works, that's when I think we're going to see trust in AI as far as the protocols really make a difference.
Alice, any comments on that? I think you and I think you were talking about the wearable devices, and makes me think of a colleague at Nike who was working on a program engineering a new generation of socks for your feet that would track a number of health indicators just from what's on your feet. So any perspectives on that and how that will be part of this?
Yeah, I think I would just give a +1 to John's comment here, which is as people see the value or the accuracy of the tools that they work with, they'll develop more of this trust over time. And I've seen a lot of, I think, startups sort of some of them have moved away from trying to take on the diagnostic kind of challenges into more the operational challenges. There are a lot of medical scribes now to sort of save clinicians time in taking accurate notes. And so, the scribe will take an attempt at sort of transcribing all of what's happening in the conversation, and the medical provider can read over those notes and see like, oh, it actually did understand my conversation. It summarized it accurately. That can help, I think, build trust in the model actually listening and understanding kind of the context of the conversation. I think people are kind of investing more in AI for operations, for triaging patients to emergency rooms or to the right providers, or to know like if they should go in for a medical imaging kind of exam, which might be costly. So these sort of things around the actual diagnostic experience that can be costly or time intensive for the healthcare provider, but where maybe the cost of being wrong is lower than getting a diagnosis wrong.
See, really helpful. We were kind of quick early on to talk over to bypass ChatGPT, as though we've already figured out how ChatGPT changes the world, and now we're thinking about the next generation. But we're still figuring out how ChatGPT is changing the space that we work in. And the first time that I saw ChatGPT work in our space, somebody asked the question, what are the top 5 causes of maternal mortality in Sierra Leone? And they put it in, and within about 2 seconds, they had 5 paragraphs of really well thought through text. And we all looked at it and said, yeah, that sounds right. And a more up-to-date example was another colleague who had something on climate mitigation in health facilities. And what are the top factors that health facilities should consider in terms of climate mitigation? And they came up with maybe 10 really good ideas, including ones that I had never heard of or heard of, but not thought about in this context. So in our space, it's a competitive advantage if we can use something like ChatGPT to check our assumptions, to make sure that we are thinking well about ideas, but also to maybe give us an idea that we hadn't thought about before. So that's a benefit of ChatGPT. Probably there will be more things like that coming along.
Doug, and I think one of the things that's key there is knowing how to ask the question of ChatGPT makes all the difference in the world. And there's a ton you can ask, Google, say, give me guides to writing a good prompt, is what it's called. But if you ask, say, I am a person who lives in Sierra Leone, I am this age, I've had these life experiences, I'm currently in this situation, what are the 5 things that a doctor might recommend to that person? The more you design in the context and really specific information, you'll really be surprised how much more valuable data the system then generates for you.
Fascinating.
Yeah. So I think that also represents an opportunity. For instance, my own country, Ghana, the mobile phone penetration is about 113% in the entire country. And so, yes, I mean, it's one of the highest, countries with mobile phone penetration in Sub-Saharan Africa. I think it's about the way we also probably educate some form of literacy on how to use such apps. I mean, for health and well-being, to seek care. Now, for instance, teenage pregnancy has a lot of stigma, and so of sexual reproductive health and rights. So it is one area where if we are able to educate certain vulnerable groups and the rest, they'll be able to ask questions, necessary questions on the chat, using their mobile phone with the search app, and possibly direct them to certain care providers that will be able to support them. So it is one possible area which is not optimized at all. Apart from sending WhatsApp messages and others, we can also harness the power and use of mobile phones within certain age, even in remote parts of the country or certain areas, to ask relevant questions. Of course, that requires training, education, engagement, to ensure that they also benefit, from, this novel AI, evolution that we are talking about. Over.
Well, Peter, I was just reflecting back on the notes also in terms of policy leadership. And I want to return to one thing early on that Melody was speaking of. Melody, sorry, I'm reading a comment that Alice was speaking about the data and safeguarding the data that goes into these factors. And I'm really thinking about your context and the need to support leadership there to make effective policy decisions. Alice, is there something concrete if you thought about, there's a lot of information about sharing patient data generally out there, but is there something targeted to AI that we should be helping put into the hands of our local members in many countries so that when they go advocate, they can say, here's something you should be aware of, this is a risk, this is an opportunity, but please be aware. Maybe a fact sheet or something that you've seen that is effective on this.
I think I can share a resource for the notes for you to distribute after this session.
And related to that, there was a question for the whole panel about, is there a think tank looking at how we may look at forging the next generation of health and medical roles, such as what volunteers, community healthcare workers can do, what new roles to train these new layers of health workers, new roles for medical missionaries, other levels of personnel to be trained short of medical doctor. Is there a think tank that's thinking about this right now? And I'm really thinking about the faith-based landscape. Maybe there's something beyond faith-based. Have you guys seen anything? Any group out there that you think is leading on that?
Well, so potentially a webinar like this as part of the leadership drive. And we commend CCIH for even beginning a conversation such as this. I mean, it will gain traction. And of course, I mean, faith-based actors will start even talking about the whole AI and its potential impact or use of AI within the entire system. I think talking about think tanks are great. They can provide a preliminary leadership, but the think tanks should also help in ensuring all-inclusive participatory AI development and deployment. Why do I say so? Sometimes think tanks have a way of thinking that they know everything that is right. And their recommendation may lack context, especially in our case, we are seeing the explosion of vendors, AI vendors coming in, designing their own thing without including others. So leadership that we are talking, leader for AI, for faith-based actors is very critical, aware of our common mandate of ensuring that we reach out to the unreached, marginalized, and neglected, especially in areas that are underserved. And I think this should be the beginning of revolutionizing leadership as far as AI is concerned for faith-based actors. And I think from this, some of the recommendations, perspectives, and insight gain should lead into Christian health associations or FBO actors beginning the discussion. And one, how do we even conscientize our own constituencies, our church leaders, aware that the faith-based actors have one of the convening platforms? How can we leverage AI for health promoting practices? How can we even train our nurses, doctors in our medical schools and nursing training college on this? How can we infuse in management within the entire system and the whole architecture of that? And how can we even start thinking of governance, leadership and governance with whole AI? I think this represents one of the opportunities that we can begin to leverage. And I think that this webinar probably is a revolutionary act. Of course, gentle in approach, but of course, revolutionary in impact. That's what we're expecting. Over.
Well, I'll make that my motto: gentle in approach, but revolutionary in impact. That sounds good. We're winding down to the last few minutes. Two things that I want to do. I'm going to put one question for closing thoughts that just came in from the audience. What area of ministry or community health do you think will see the greatest disruption, overhaul, or change from AI? So what area of ministry, community health, ministry or community health do you think will see the greatest disruption, overhaul, or change from AI? So think about that for a moment, and we'll give you just less than a minute to comment on that in closing. And then I think we're going to go ahead and share the resources. I spoke at the beginning about 4 resources, including the helpful piece that Alice wrote, as well as a USAID publication on AI. There, we didn't want to share that because we knew the clicking on those, but click on those before you get off this this webinar so that you can get them open, and we will share them also in the email that comes out after. So let me come back around to that question. What area of ministry or community health do you think will be the greatest, have the greatest disruption? John, we'll start with you.
Yeah, this isn't my direct field, so I won't have as much insight, but I would say that the greatest disruption will happen where the most data exists. And so in the areas of policy, of assessing, where things are happening, where diseases are prevalent, that whole area of looking at trends and all that is going to go through a huge overhaul. And the way it's done now will not be the way it's done in the future. The expectation of immediate data available on the status of malaria in a certain county or province or country, et cetera, is going to just be very, very different. So I think that whole area of analysis, assessment, and then decision making around healthcare, I would imagine, is going to see a lot of disruption.
Excellent. Alice, to you.
Yeah, I think remote monitoring and telehealth is likely to see a lot of disruption. I think that was really spurred by the pandemic, but in the US, it's true as well that many rural communities don't have access to healthcare or have to travel far distances to be able to see a doctor or especially a specialist. So I think the ability to bring care to where people are by having them have devices or even just their mobile phones that can provide information and telemetry and have that be triaged and analyzed and diagnosed with, I think that'll really open up access to communities that are typically very hard to reach with medical care and might be unlikely to ever get really specialized medical care.
And even without long distances, the traffic, epic traffic in many of our large cities is enough of a barrier too. Great thought. Peter, final thought about that.
Well, which areas would AI likely to have a higher impact, most impact, if I understand that question to be? Well, remember our mission, our core mission is reaching out, equitable access to the highest attainable health services. So if AI could really be enabler for quality, for efficiency, for equity, certainly AI is going to have a higher impact. And telehealth, remote care is very important. Health system strengthening is important. The extent to which AI not only helps with diagnosis and treatment, but also strengthening like human resource use and deployment so that everybody from afar will have access to it. Supply chain issues, extremely important, financing models and others. So certainly, if AI could well be impactful, let's see how we can couch AI to be a complement and not a competitor, a complement in terms of strengthening the entire faith-based health system from leadership to governance, for service provision and all actors. And I think certainly if we can look at investment case and inclusive participation, AI will be much more responsible and ethically acceptable, and of course, highly impactful in bridging health inequalities and gaps all over, and ensuring access to quality health services for all the needy, and impact gender, geography, and generations from afar. Over.
Excellent. Wow. Well, thank you. Thank you for that. Thank you for those closing remarks from each of you. I have really learned a lot from this time, and I'm sincere in saying that. This has been a time of growth for me and to challenge some of my own thinking. I believe, therefore, it's also the same for the many participants who have engaged with us. So Alice, John, Peter, thank you for taking time with us today. We're grateful for that, and for all of the participants who got on with us. Thank you. You already saw the link come up for a one-question survey, literally a one-question survey. So it's right there in your chat. Take a second, click on that, and answer it. It would be very helpful for us. Thank you all. Really appreciate the time.
With pleasure.
Thank you.
Blessings.